All right, let's get right into it. Today we're tackling a topic that is absolutely essential for any dental professional in the UK, especially if you've got exams coming up. We're breaking down the official UK guidelines for antibiotic prophylaxis against infective endocarditis. This is need-to-know stuff, so let's dive in.
So here's our game plan. First, we'll cover what infective endocarditis actually is. Then, we'll get into the big one, the main guideline. After that, we'll pinpoint who we mean by at-risk patients and which dental procedures are considered invasive. We'll touch on the rare exceptions and wrap up with the exact drug protocol if you ever need it. Simple as that.
Okay, first things first. Before we get into the rules and regulations, we have to be super clear on what we're actually trying to prevent here. So, infective endocarditis, or IE for short, is an infection of the inner lining of the heart. Think of bacteria getting into the bloodstream, traveling to the heart, and setting up camp on the heart valves. It's rare, yeah, but it's incredibly serious. And just how serious are we talking? Well, the case fatality rate is around 30%. Let that sink in. This is a life-threatening condition. And that's exactly why these guidelines exist and why your role as a dentist is so incredibly important. Which brings us to the million-dollar question for every clinician, right? We know IE is dangerous. But when does something you do in the dental chair mean you have to step in and take specific action to prevent it? And here's where things get really interesting, because the answer has changed a lot over the years. Let's look at the absolute core principle from NICE, the National Institute for Health and Care Excellence. And there it is. This is probably the single most important sentence you need to remember. And the magic word here, it's routinely. Antibiotic cover is not recommended routinely. The default position in the UK has completely shifted. For most patients, even high-risk ones, we no longer give antibiotics as a standard precaution.
So you might be asking, why the big change? Well, our understanding of the science has evolved. You see, the old thinking was that a big burst of bacteria from something like an extraction was the main danger. But what we now know is that the bigger risk actually comes from the cumulative, constant, low-grade trickle of bacteria from everyday things, like brushing your teeth or even just chewing your food.
And that leads us to the most powerful takeaway for your day-to-day practice. The absolute best thing you can do to protect your at-risk patients isn't writing a prescription. It's coaching them, motivating them, and helping them achieve fantastic oral hygiene. That lowers their daily bacterial load, which we now know is the real enemy here. Okay, so we've established the no routine prophylaxis rule. Now let's get specific. Who exactly are we talking about when we say at risk? You need to be able to spot these patients from their medical history. This slide is your checklist. These are the high-risk cardiac conditions. We're looking for patients with acquired valve disease, anyone who's had a valve replacement, those with specific structural congenital heart diseases, hypertrophic cardiomyopathy, and this is a big one, anyone who has had IE before. They are at the highest risk of it happening again. Now, identifying the patient is just one piece of the puzzle. The other piece is the procedure itself. Because the risk is really about the combination. A high-risk patient having a procedure that's likely to cause a significant bacteremia. So which procedures should make you stop and think? Well, here's your list. It's basically anything that involves getting into the gingival tissues or the periapical area. So, of course, extractions, deep scaling and root planing, any kind of perio or endosurgery, and placing dental implants. These are the ones we consider invasive in this context.
And just as important is knowing what's not on that list. You do not need to worry about prophylaxis for things like routine local anesthetic injections, fillings that stay above the gum line, taking x-rays, or fitting ortho brackets. Knowing when not to worry is a huge part of confident practice.
Okay, so let's get into the nuance. We said prophylaxis isn't given routinely. That little word implies that there might be some very specific, non-routine situations where you might consider it. Let's look at that rare exception. Now, this is crucial. This is not a decision you make on your own. If you've got a patient from the high-risk list and they're about to have a procedure from the invasive list, you have a clear process to follow. It starts with a conversation with the patient. But then, and this is the key part, you must liaise with their cardiologist or cardiac team. So let's be crystal clear, giving antibiotic prophylaxis is the rare exception to the rule, and it is always, always a shared decision made in consultation with medical specialists. It's not just a dental call, it's a collaborative medical decision based on that specific patient's unique circumstances. All right, so let's imagine you've gone through that whole process. You've consulted with the medical team, and together, you've all decided that for this one particular patient, antibiotic cover is the right call. What do you actually prescribe? This is pure must-know examinable stuff. Luckily, the protocol is very straightforward. For most patients, it's a single 3-gram oral dose of amoxicillin taken 1 hour before you start the procedure, and if your patient has a penicillin allergy, the go-to alternative is a single 600 milligram oral dose of clindamycin, also taken an hour beforehand. That's it, simple and clear.
And it's worth knowing that everything we've talked about is based on those national NICE guidelines. And they're supported by really practical advice from groups like the Scottish Dental Clinical Effectiveness Programme, or SDCEP. So you can be confident this is the official UK standard of care.
So I'll leave you with this question to think about, because knowing the rules is one thing, but really applying the principle behind them is what matters. The biggest takeaway here isn't about which antibiotic to give, it's about shifting the focus to prevention through great oral health. So how are you going to make sure that every single at-risk patient in your chair understands that the best defense they have against this disease is the toothbrush in their bathroom?